This is the fourth out of a series of 5. So we've done a report on methamphetamine, we've done a report in tobacco, we've done a report on non-medical use of opioids, which came out relatively recently, and this is the 4th one on cannabis. We are just starting out on a report on alcohol, and when that one comes out, I'm going to retire. Because they do create sometimes some contentions from various vested interests, as you could imagine. And so it is a significant team, and we do also send the report out for external review. And the whole process is dependent on quality data. And when you start delving into this, you realise that there are enormous gaps in data. Robert and I were really surprised when we got to tobacco. We thought, and Akeef, who's actually also part of the team here, we thought tobacco would be really easy, but it's actually been an incredible challenge. There are still gaps in what we know about what tobacco's contribution might be to X and Y, and contention about some areas. But there are other areas where there are enormous gaps. So, for example, you might expect from what we understand of alcohol and drug problems, it doesn't just affect the individual consumer sometimes, it can also affect other people, such as family members and children. But when you start delving down into the data, you find that outside of alcohol and tobacco, the quality of the information doesn't allow us to be bold about our conclusions there. So one of the things we've done is make estimates that have had high bound and low bound, and we've taken the central estimate so that we've tried to be conservative. We've also left out information where so we might have calculated what we think the cost to children might be, but we've left that out of the overall total that we've included because, as we've said, we're not confident about that. So we're going to take you on the journey, but it is important to recognise that it comes out of data, sometimes high quality data, sometimes data where there are particular gaps, sometimes data where there's confusion, and cannabis is a good illustration of that. So people might, for example, in relation to the workplace or accidents or driving, might say that cannabis was a contributor, but it's based on cannabis metabolites, which may be present several days after somebody's actually consumed cannabis. So whether or not cannabis intoxication was a component of an outcome is something that's debatable. So essentially, I'm going to hand over at this point to Robert, and he's going to take you through the first part, and then I'm going to come in to talk about crime and workplace.
I'd also like to start by acknowledging the traditional owners of the land and their elders, past, present and future. So I'm just going to give you a background information about why this has come apart now, a quick overview of the results and some of the cost areas involved. The criminal justice system was the most expensive. We're also going to look at morbidity and treatment costs and workplace costs. Those are the really big packages. Steve.
Sorry, Bob, before you start, there's something very echoey about the sound. Do you need to use the microphone?
It was just to try and pick up on there, but
I'd turn it off. It's quite a thick sound and echoey.
Sounds like cotton ball.
Yeah, no problem at all.
That's beautiful.
Yep, that's better. Yep, okay. As Steve said, most of the time I'm going to be talking about our central estimate, but be aware that there's often a wide range around that, and we'll come back to that at the end. Okay, that was it. So, a bit of background here. I'm sure you're all aware that the global status of cannabis is changing. Some jurisdictions have legalised it, some have decriminalised it. But there are also some other changes going on around the potency of cannabis, the ratio of cannabis and cannabidiol, which might have adverse health effects. There are also changes in the modes of use, so there's vaping of cannabis oil. All of these might have health effects. We're not going to touch on medical marijuana at all, other than to say that obviously that in the States has led to some changes in prevalence of use, which again might have impacts on the health effects. And finally, the last major analysis we can find of the social cost in Australia is back in 2007. This data comes from the National Drug Strategy Household Survey back in 1993. The black line is the declining smoking, daily prevalence of smoking, just as a comparison. And the orange line, the brown line on this screen, is the prevalence of recent use, the last 12-month use of cannabis. And as you can see, other than that one blip, it's been fairly steady over these years. So what does that work out in the number of people? If we use the National Drug Strategy Household Survey, there are about 2 million people who have used in the last year. That's people aged 14 and older. But on some of these measures, we're wanting to look at people who are dependent on cannabis, and you can't get that information from that survey. So we turn to the global burden of disease. And there's about 150,000 people in Australia who meet the criteria for being clinically dependent on cannabis. I really hope there aren't any economists in the room, because if anyone wants to ask about economic modelling, the answer's going to be, I'll take that on notice, or palm you off onto Steve Wetton, who's our economics genius. So what are we going to do with a social cost study? Well, here we're looking at the overall costs of an illness or a condition or a behaviour. And that's going to sum across a wide variety of areas, so health, justice, workplace productivity, impacts on children, road crash accidents. And because all of those have different outcome measures, you need to turn those into dollars. The major criticism of social cost studies is they just come up with a big number, and they don't tell you what to do about it. There's no recommendation for the best intervention or treatment. There's also a lot of debate about what you should include in your study and what you should exclude. So, for example, should you include the cost of cannabis that someone has to pay to buy it? We'll come to that later. Nevertheless, social cost studies are sought by the government to inform change, and also by advocacy groups, of course. And it aids in identifying those high-cost areas where you might be able to change interventions or possibly even change policy. So we've done 4 of these already, so we're following basically the same model. This followed the opiate model most closely, but even there's 1 or 2 slight differences. I'll come to one of them a bit later on. So we do a literature review, we look for evidence of potential harms arising from cannabis, and we got our evidence of that from the global burden of disease. Then you need to find out whether there's any Australian data you can use to assess those harms. You need to quantify those harms, and then you need to turn those harms into dollars. Sorry, this is a bit difficult to read. These are the conditions that the global burden of disease says are attributable to cannabis, except for bronchitis down at the bottom there. We'll come to that in a second. And you'll also see that some of these are labelled as wholly attributable to cannabis, and some of them are partially attributable to cannabis. So if you go into hospital and you're diagnosed with cannabis withdrawal, that's wholly caused by cannabis, and we're going to cost that admission completely to cannabis. If you go in there with schizophrenia or depression or motor vehicle accidents, there are obviously many causes of those, of which cannabis is only one. If you have good evidence through epidemiology on relative risks and the prevalence of use, you can then work out what proportion of those cases should be attributable to cannabis, and that's what we've done for those cases. Low birth weight is definitely attributable to cannabis, partially attributable to cannabis. We had good relative risk data, but we couldn't find what we thought was good enough data in Australia on women using cannabis when they were pregnant, so we haven't calculated that. Chronic bronchitis wasn't in the global burden of disease, but we found a couple more studies published since the last update, so we included it. It's actually made a very small difference, but it's not in the global burden of disease. One final point, synthetic cannabinoids. We've tried to exclude those through the report. I'm sure some of you will know about the pharmacology of them, whether they're actually cannabinoids or not is another matter, what they're sold as. But as far as ICD-10 codes are concerned, at the moment they can't be split off, so some of the ones that are attributable to cannabis in ICD-10 codes will be synthetic cannabis. There's nothing to about that. So the methods, again, followed the same approach we've done previously. We were looking at the prevalence, so what cases occurred, not just the first instance of a case. We targeted a single year, 2015 and 16. When we started this report, that was the most recent data we'd get, or most recent and reasonably complete data we'd get, for example, on mortality and the hospital data. The one exception to this single year, 2 exceptions, are premature mortality and there's another one in road traffic accidents, where there's good evidence of how those costs go out over a lifetime, and we've used the lifetime costs for premature mortality. We discount that back to what the value of that money's worth in 2015 and 16. There's nothing in here about the benefits to users, so if people are getting pleasure from their drug use, if they're getting enjoyable social experiences, if they're claiming it's reducing their anxiety, those aren't included here. As Steve said, there are some more contentious areas where we haven't included costs. For example, the purchase of cannabis by cannabis users. Economic theory would say, if you decide to buy something, you're going to gain a benefit from that which is either equal or greater than the cost of buying that product. That's fair enough, but there's an argument that people, once they reach the criteria of being dependent on a drug, are not solely motivated to buy that drug because of the benefit they're going to get. There might be some emphasis on relieving withdrawal symptoms. So there is some justification for including those personal costs for people who are dependent. But we've separated those out from our main estimate. And the other area we've separated out is what are the costs of living with someone who's dependent? So are the harms, lost quality of life to children and partners of someone who has dependence? There's some evidence around that in terms of alcohol use, the harms to others projects that my colleague Anne-Marie Laslett has worked on, but there really is very little on those costs in terms of illicit drug use. So again, we've made an estimate, but we haven't included it. So the 6 areas I'm going to be talking about: premature mortality, healthcare, criminal justice, workplace, road traffic, and just an example of a couple of other costs we'll be looking at. And the last 2 of those are more contentious areas. We won't be going into those today. So with premature mortality, this was led by our colleagues over in Sydney at NDRI. And to start with, we used the method exactly as we had done in opioid use. They have access already to the National Coronial Information System on all deaths in Australia. And they tried to identify there any deaths that were wholly attributable to cannabis. And there were no deaths that had been wholly attributable to cannabis in that system. So we then used the method that we used in assessing tobacco, which is the attributable fraction method in terms of deaths. Using that method, identified 0.1 of a death due to chronic bronchitis and 23 road crash deaths. So once you've identified those deaths, you then look at the age they occurred at, work out how many years they would have life they've lost on average, and you work out what the tangible costs of those are. So they're no longer contributing at home, they're no longer contributing at work. There are costs to employers of replacing a worker who's died. But the government is also going to make some savings. They're saving on benefits and healthcare costs later in that person's life. So that's why we've got a net cost here. We've taken off those savings that the government's making. And that's 28.9 million. But there are also intangible costs. So when you die, you've lost those future years of life. Those have a value. There is some level of contention about valuing years of life lost. It's not universally accepted, but it's used in a number of places, particularly for things like tobacco, where you have so many people dying. You would completely underestimate the harms of tobacco if you didn't include intangible costs. We estimated that at 106 million. Just by way of comparison, in a year, tobacco use kills more than 20,000 Australians. Illicit use of opioids, over 2,000 Australians. Methamphetamine, 170, cannabis, 23. Those are the figures from our reports. So the next thing we looked at, again led by our colleagues over at NDRI, was the cost of being an inpatient. And the source is the AIHW's National Hospital Morbidity Database. So from conditions where it was wholly attributable to cannabis, so those cannabis withdrawal, cannabis diagnosis, we included the entire cost of that admission as an eligible cost. For those other conditions like depression, schizophrenia, car crash injuries, we worked out what proportion of the number of events should be attributable to cannabis, and then costed each one of those on an average basis for those conditions from Australian related diagnostic rated group codes. there were about 13,000 hospital separations that we identified. Cannabis was responsible for 6.4% of the alcohol and drug presentations and contributed 0.45% of the total cost of inpatients. And that's the total for inpatient costs. Unfortunately, things now get a lot more complicated. For all the other areas of healthcare, we had different data sets, different assumptions, and so we simply don't have time to go through all of these. If it's an area you're interested in, please look at the report or talk to me afterwards. I'll talk through a couple of them just to show you the sort of methods we used. So outpatient care, well, it's actually called non-admitted outpatients now. So here's an example of where there's going to be a very wide estimate in terms of that range of costs. So the AIHW report says there are about 860,000 alcohol and drug events in our target year. Looking at the inpatient data, we say that 6.4% of those are due to cannabis. That works out at 55,000 events. From the AIHW report, we can work out the average cost of an outpatient presentation, $303, multiplied by 55,000 gives you 16 million as our low bound. We were much more unsure about the upper bound. So we were in the dilemma here. Do you have something that increases that confidence interval, but that will bump up our overall price? So that needs to be considered here. So we said for the high bound, we would use 6.4% of the total costs, and that comes out at 34 million. The midpoint of that is $180 million on outpatient care. Another area we looked at was the cost of drug treatment services. There's really excellent data on the number of episodes of care, national data, but we could find nothing in terms of national costings for the different types of care that people receive. We're very grateful to the Mental Health Commission back in 2013 who provided us some information on their estimate of the different types of costs for different types of treatment in WA. So we know from the national data there are 201,000 episodes of care. We know what proportion of those were there for primary drug of cannabis, 45,000. And we have those estimates of different costs for different types of treatment. So initial assessment, whether you have counselling, whether you have drug detoxification, so each had different prices. And on that basis, we worked out that the treatment of cannabis use in that 1 year cost 87 million. But there are also other people who come in not for the treatment for their own drug use, but treatment for a partner's drug use, say. We don't know what drug that person is using, so we allocated these people on the same ratio as cannabis to total drugs. And obviously, they're not going to be having some of the more expensive interventions like detoxification, residential rehabilitation. So that comes out at 3 million for those people. We looked at medications for treatment of illnesses caused by cannabis. In tobacco use, this was a huge expense. So this is PBS medication we're looking at here. We're only looking at 3 conditions: psychosis, depression, and chronic bronchitis. The PBS website will provide you with total costs for all antidepressants prescribed in a year, antipsychotics, and then the asthma-type medications for bronchitis. Again, we worked out a low bound. So for each condition, for example, depression, we looked at the proportion of cases of inpatient separations that were attributable to cannabis, and we said that 1.81% of hospital separations where depression was the diagnosis were due to cannabis. So we then multiplied the total cost of antidepressant medication by 1.81 to give us $8 million. We did that for the 3 different sets of medications, and that gave us the low bound there of 24 million. The high bound, this time we've used the total cost, so we've said that for the high bound, hospital inpatients, cannabis was responsible for 0.45%. We're much more certain of the diagnosis is here, so we'll use that tighter bound, and that gives a total of 54 million. Across all the healthcare system, that's $500 million worth of costings. and that's an area chart. So outpatient costs may be a little inflated. We've looked at general practice, or primary care, which is general practice and referred services, drug treatment services, community mental health, there's medications, ambulance VD. We also looked at some of the costs of caring for someone with conditions caused by cannabis.
Okay, I mean, one of the things that's really important to recognise in all this is, because you're going into so many different data sources, there's a whole range of different expertise that you have to bring in. If we hadn't had a Keith who works part-time with us and part-time with the health department, we wouldn't have the same access and understanding of data, access to and understanding of data that exists in the health system. If we hadn't had the work that Tanya and that Anne-Marie had done, we would have had less capability of doing assessments of child costs in relation to childcare and child deaths. So you have to bring in a range of expertise. But what this study also shows, and the previous ones as well, is that on the one hand we end up with an estimate, but it really highlights the dearth of data that we have, and also the ability to get timely data. So 2015-16 is when we did this, because that was the last period of time we could actually get as full a set of data as possible, even though we were releasing the report in 2020. So it actually, the study doesn't just give a figure to say, well, there's this estimate. It's also telling us there's these huge gaps in our understanding of alcohol and other drug use, and that has implications for cost estimates, but it also has major implications for policy and service planning and response planning. And so it really shows where we have to put enormous effort to get much more accurate and much more current data. It becomes an even bigger challenge when you start looking at the criminal justice area. First thing to point out is that the majority of the costs here, cannabis by far is the most commonly used, currently illegal drug by manyfold. But the health costs, as Robert's pointed out, are significantly lower. Obviously, that prevalence can have an impact on the criminal justice area. It's the much larger number of people who come into contact with law enforcement. But we simply don't have systematic data that are gathered in the justice and policing area that lend themselves well to meaningful statistical analysis. So it's the role of drugs in crime and alcohol is not routinely assessed, which is a huge gap. It doesn't allow us to make judgment about the impact of law enforcement, let alone what the costs actually might be. So the only regular survey is called JUMA, which is a survey that's managed by the Australian Institute of Criminology. And our colleagues in New South Wales, Neil Donnelly, who's an adjunct with us, they were responsible for looking at the crime data for us. JUMA, if you're not familiar with it, is where people who come into contact, in Western Australia it's still just one lockup, is my understanding, East Perth lockup. So, it's the people who come into contact with East Perth lockup, not the people in other lockups, not people in Broome, Derby, Albany, just one lockup in each jurisdiction. And then they have to give, firstly, they can't be intoxicated. So it excludes those people who are currently intoxicated. It excludes people who don't give their consent. So it's only people who give their consent. And you can imagine when you're in a lockup, your motivation to say cannabis contributed or didn't contribute to your current crime may be biased in one way or another way. So it's not surprisingly that it's not representative, but it's the best we have. So we have to work on the basis of it. As you use this as your denominators and enumerators as you move out of people in police lockups to people in the court system, to people in the prison system, as you get further and further away from your point of interest. So we became much less comfortable with the estimates. But they are, on the other hand, they're the estimates that are available to us. I should also point out that obviously the legal status of drugs has implications for the cost estimates. But on the other hand, they don't allow us to make, some people have said, well, what do you think will happen if these drugs are legalized or their legal status is changed? We can't make that assessment from this. There are other studies that do allow us to make those, but our study is what are the costs under the current system. Can't see the arrow on this. So these are the attributions of people in the lockups, main city lockups in each of the jurisdictions. And this is their own attribution. So recognize the limitations of that in the first place. But just taking you along this, so 7.6%, if you look at the top line, of people who were in there for a violent crime, 7.6% of them attributed a part of that to their cannabis use. Or 1.7% of people who were in for driving under the influence related crime. So on average, across those various domains, 8% of people in East Perth lockup and their equivalents in other jurisdictions attributed what happened to them to their cannabis use. Again, recognising the limitations that exist with that. So that's, you can see there, these are, again, the other thing is the sample size is pretty small. So these are the sample sizes of the people who have said, yes, cannabis contributed to my violent crime, as a proportion of the total number of people in the justice system in that same period of time. Small sample, highly likely to be biased by all sorts of reasons, but that's the data that we have available. So if we want to look at where we need to improve our databases, this is one obvious one. When we work on those estimates, we also then, I'll just go back before I show this one. The other thing that we needed to do then was say, well, what proportion of police time? Now, it isn't 100% of police time isn't spent on addressing crime. There's a whole range of other things that police do. So it's about 80% of police time is actually on addressing directly criminal involvement, catching criminals, and so on. And then we had to exclude, because we were looking at adults, their involvement in juvenile crime. So we ended up with a proportion of police time, and we can estimate what the overall cost of policing in Australia is. We're not talking about border interdiction now, we're talking about state and territory policing. And we can make an estimate of what the costs are. So then we would say the proportion of this 8% of that cost is in relation to cannabis. So a similar process to what we used with the healthcare costs, with probably a little less confidence about it. So you can see that a significant proportion, 474 million, is spent on police time on crime that is cannabis related. You can see, however, when we get to the courts, and this excludes the specialist drug courts, but if you're looking at magistrate and high courts, and I'm not going to go through all this, legal aid, that doesn't include the expenditure that an individual might have of their own. This is about legal aid. We weren't able to estimate individuals' personal expenditure on defending any crime that they might be up for. And then, of course, the cost of imprisonment. Now, why government payments it is supposed to be in orange, but there's something with the camera here, is that, of course, when somebody goes into prison, there are savings to government if those people are on welfare, because they stop getting their welfare benefits. So we've calculated that in as a gain, if you like. It's a net loss overall anyway, but nevertheless we've calculated that in. And so you can see there that there are just under 3,500 cannabis-related sentences. There was 304,000, nearly 305,000 hours of community supervision. So you're able to make some estimates. But as soon as you start getting away from police, getting people into lockups, into supervision orders, into courts, you become less confident about how well your calculations work. But these are the sorts of costs, and here you have the tangible costs that you can calculate. The intangible costs are the impact on people beyond tangible costs. So, for example, if somebody breaks into your house, there's the cost of that break into your house and the police involvement in that. But there's an intangible cost of quality of life which may follow on from that. And there is a body of work that allows you to make estimations about what that downstream impact might be on people's quality of life. The sort of thing that you might see in impact statements, for example, victim impact statements, and how that might affect your life. So if you've ever been burgled or you know someone's been burgled, it's not just the cost of replacing the television, it might be the cost on the quality of life subsequent to that. So again, I'm not going to go through all of these, but it meant that our costs were significant in relation to crime. Remembering that this is based on self-attribution of a biased sample or a sample that might have some bias in terms of its selection. It's not a random selection across all criminal involvement in the country. So you can see that the largest part of time is actually in the policing and the imprisonment areas. And this attests to the way in which laws might be enforced. It attests to the size of the population. It attests to the consequences, not just directly of drug use, but the legality of drug use as well. This is Simon Lenton's office on Friday afternoon. All of you go home at 3 o'clock on a Friday will miss this. That's Simon wearing his disguise in the middle. And of course, there are potential costs in the workplace. Again, there are limitations to these data. So data are drawn from health and safety systems. Data are also drawn from drug testing. And again, someone might use cannabis on a Friday night, turn up to work on a Monday morning, have a positive drug test. Whether or not that positivity, if you like, of drug metabolites is indicative of any impact on well-being or safety or productivity is clearly debatable. Essentially, in relation to workplace and driving, the evidence is that impacts on performance are most likely felt in the first 3 hours after somebody has consumed a drug, i.e. when they're intoxicated. And there's good scientific consensus on this, and there's good legal consensus on this, that positive drug tests are not necessarily indicative of impairment. They may be, they may not be. So keep that in mind. So National Centre for Education and Training on Addiction in Adelaide ran this part of the study for us. And they looked at occupational injury, again looking at data that are fairly old now. It doesn't include mortality in road traffic accidents, which may happen in relation to the workplace because they're counted elsewhere. So driving accidents were counted under driving rather than under workplace, and so that we avoided any double counting of somebody appearing in the workplace and in a driving accident. It's the relative risk of injuries in relation to preventive effort of cannabis-affected workers, and that's through drug testing. And a very large Australian drug testing company, which doesn't cover everybody in Australia, but does have a very large sample base. And also they looked at the severity level of an injury, but also you can make an estimate of that through compensation. I did some work in Scotland 40 years ago, looking at alcohol and related injuries in the workplace. And what we found was that not only was there a contribution to workplace accidents, they were more likely to take much more time off. So the severity in terms of time off work after an alcohol-related accident was much higher than for other conditions. And also they looked at the National Drug Strategy Household Survey data from 2015-16 in terms of reported absenteeism. There is an estimate that sometimes it's made in relation to presenteeism, which is where you turn up to work and don't do anything. So, if somebody's got a hangover, they turn up to work, but, like me and Tanya today, they sat down and had a coffee. So we're presenteeism. So it looked at whether or not there was cannabis, whether other illicit drug use, no illicit drug use. And the estimates are based on whether or not there's injury plus illness or injury without illness, and whether there was absenteeism related to drug use. In the analysis, they control for age, sex, marital status, socioeconomic status, and occupation. And they also adjusted, obviously, as much as you possibly can, because often people aren't just an alcohol user, they might also be a smoker, and in the same way somebody might be a cannabis user, but they might also drink heavily, they might also smoke tobacco. So there were adjustments made to try and account for that. And as I said, in this study we didn't include presenteeism because there's no evidence that can allow us to make any conclusions about it. So again, you can see significant costs in relation to workplace injuries, the estimate, recognising the limitations of the conclusions that we can reach was just under 300 million, and absenteeism was 260 million. So in essence, the total cost to workplace was estimated at 560 million. Again, recognising there are significant limitations to how much intoxication. Some of it's based on self-attribution, some of it's based on drug testing, some of it's based on official data. Obviously, if somebody's had an accident at work, they're not inclined to say, oh, I had a joint just before I had the accident, because that has all sorts of discipline and, of course, compensation implications. Back to you, Robert.
So I'm sure we're all aware that cannabis affects your coordination and your driving abilities. But there's also evidence that people who are affected by cannabis try to drive more slowly to compensate for that. But unfortunately, it doesn't completely compensate for that. From hospital data, 8.6% of fatal crashes had active THC, so not metabolites, so had cannabis in their system, and 7.6% of serious injuries also had active THC. So as Steve said, we're trying to ensure we don't have any double counting, so we're excluding the cost of lives lost here and hospital separations in this section of the report. We're looking at their long-term care costs, their insurance costs, property damage, legal fees, and workplace disruption. We've got the relative risk from work by Wayne Hall, as Steve said. That's really about the first 1 to 3 hours after use. Again, prevalence is a really difficult thing to estimate here. A lot of the data comes from police drug testing, drug stops, but they're likely to be targeted at high-risk times and areas. This is the only study we managed to find that used a random sample of people, and so they estimated that 1.3% of drivers are intoxicated with cannabis. The key data comes from the Bureau of Infrastructure, Transport and Regional Economics, and it's based on information from 2006, and this is the last data that has really separated out the different severities of crashes. And from that, there are about 11,000 cannabis crashes and about 4,200 cannabis-related crash injuries. So we simply updated the Bright data to reflect the increasing population and the increasing number of cars on the road. But unfortunately you can't do anything about whether the cars have changed safety levels. Long-term care, we've used two approaches, so it's not exactly the same as Bright. To start with, we estimated a low bound based on some Victorian data on compensation payments, so that actually tells you how much was paid out to victims, and we've extrapolated that across the country. Again, you have to assume that, or we assume that the level of compensation will be similar across the country. For the high bound, we followed exactly the same method as Bright did, and they looked at different levels of injury severity. They estimate the level of care that's going to require over many years, any modification to the house, and this was the other instance I was talking about that's not just based on a single years of evidence. They've looked at lifetime costs if, let's say, someone's got a major injury, and then those costs are discounted back to what that money would be worth in 2015-16. And that actually turns out to be the major cost area, the long-term care cost at $130 million. Steve's said quite a lot about quality of data. I think he's covered all that there. I suppose the one thing here is, are cannabis cases more or less severe than the average case? So we said that people tend to drive more slowly when they know they're affected by cannabis. So the speed of a vehicle has a lot to do with the severity of the injuries. But we saw from that very first line I showed you the percentage of road fatalities and serious injuries that had cannabis detected. So it doesn't look like that is completely offsetting it, and they are having severe crashes. I'll talk you through the child protection ones, and I'll skip through some of the other costs. We're running out of time here. This data comes from drawn from the work of Anne-Marie Laslett, and child protection data is actually very hard to get hold of, so it's difficult to get national figures on these. When I say these are cannabis caused, I think everyone in the field recognises that child protection cases have multiple causes to them. Anyway, from Victorian data, Anne-Marie Laslett identified that 35% of substantiated child protection cases were due to substance abuse, and she broke that further down into alcohol and other drugs, and drugs on their own. So based on that, in 2015-16, there were 46,000 substantiated cases, and looking at the number that would be attributable to tobacco use, cannabis use was just over 7,000, and the ones that would be alcohol and tobacco was over 8,000. So we took the total cost of child protection. We know that from government reports. That's about $4.5 billion. These are the number of cannabis cases out of that combined. Gives us 8.9%. So 8.9% of that 4.5 billion comes out at nearly $500 million. The other method, and this is where we're talking about really small numbers, was some data from South Australia. Someone was able to access case files on people who were having their first substantiated case of requiring child protection. They read through the case files and listed all the factors that were in each file for reasons that they were taken into child protection. We've summed up all those factors, and cannabis was responsible, or was mentioned in 7.6% of cases. 7.6% of 4.5 billion is 364 million. Now, of course, it would be great if they'd weighted this. So if you've got someone saying there's a cannabis problem and there's also child physical abuse, child sexual abuse in the same case, they are very unlikely to have the same impact on your decision to take that child into care. So there's obviously problems with these methods, but there's just so little data on how to get there. Because of time, I won't go through the preference there. So our total cost comes out at $4.5 billion, of which crime accounts for 53% of the criminal justice system. So you can see why Steve spent such a long time describing the problems with that estimate there. Again, I want to emphasise the width of our confidence interval, for want of a better term. So our estimates are around 4.3 for tangible, total costs 4.7, but our range here is 3 billion to over 6 billion, 3 billion to $6.5 billion. So there is a great deal of uncertainty in this field. We've talked about the difficulty of working with administrative data that's not collected for this purpose. So you're always having to make assumptions about how you should allocate costs to those data. A lot of the time we're having to generalise from a sample, whether it's a small study of 99 people or whether it's a state-based study, and extrapolate into the population. Steve mentioned some of those missing data in particularly federal police, border protection. We've got no costs there. We could have estimated juvenile crime, but the data is very old there and it's a very small sample again, so we didn't include that. As I said, there's a wide estimate there. We saw in one or two places we were able to control for polydrug use, but again, that's not controlled everywhere. And finally, drug substitution. These type of studies are predicated on the idea that if you remove the drug or the cause of the behaviour, all these costs will disappear. Clearly, in the drug use field, I think we'd all agree that they wouldn't all disappear, that there'd be some drug substitution, even if it's going to synthetic cannabinoids or another drug. So not all the costs would disappear, and that's just a challenge we have. There's some acknowledgements from our report. I'm afraid we haven't got nice printed copies of this one, but you can get it from our website. And I'd like to open up to questions.